So hello everyone, I hope I'm audible and visible to all my dear students. Let us start with this must know MCQ session in dermatology, where I will be discussing a lot of important questions. So first of all, introducing myself, I'm Dr. Chesta Aggarwal, your NEET PG educator. I have myself scored All India rank 261 in my NEET PG entrance examination, and I will help you with the simple tricks and tips to solve the questions related to dermatology. Now, before we start with the today's session, let us very quickly go through some of the important notifications. On Unacademy, we have a lot of new batches or ongoing batches. One is for the NEET PG 2023, which is an all educator batch. The next is we have a FMGE December 2022 exam batch, which is already started. I would be requesting all the students to kindly enroll in whatever courses you need yourself to be enrolled in. We have a question bank 2.0, which is now available. So anyone can use my code Chesta 10 and get yourself enrolled in that. Currently we are giving you a 20% discount. You have to use my code. The code is same, Chesta 10. This offer will end today at 11:59 p.m. So from tomorrow onwards you will not get so much of discount. So anybody interested, they can just go ahead using this code, take the subscription. Now starting with the first question of the today's session, I want all my students to kindly answer. The first question of the today's session, I hope you can see it. I don't know why the whole question is not being projected here. The question is, a 50-year-old woman with painless swelling in her left foot. The swelling started after a banal penetrating injury on the sole of a foot for 20 years ago. The X-ray of the image shows osteolytic lesions of the foot. The patient reports discharging sinuses through the lesion. What will be the diagnosis? Very nice. It's a very classical image of what is known as Madura foot. Amazing, great. But the question is, what kind of Madura foot is this? Is it a bacterial or a fungal? Now if you look very carefully the image, you can see that you have black granules. Black granules and a very classical triad of swelling, sinus and grains. A very classical triad of swelling, sinuses and grain. It is a feature of mycetoma, and because you have black grains, the answer becomes eumycetoma. The correct answer becomes eumycetoma. So very nice. If the color of the grain is black, it is eumycetoma, and if the color is yellow, it is the actinomycetoma. The next question, identify the correct match of wood slump finding here. What is the correct match of the wood slump finding? Pityriasis versicolor, which is a bluish green, erythrasma, which is a yellow color, Pseudomonas, which is a green color, and vitiligo, which is a coral red appearing lesion. What is the correct region? Identify the correct match of the Wood's lamp finding. Very nice. Amish, Yogesh, Sovik, Success, Yadav. The correct match of Wood's lamp finding would be. Please remember the Wood's lamp finding. Few points which you have to remember is the color which is seen with respect to different disease. Pityriasis versicolor, it is yellow color. Erythrasma is coral red, and vitiligo is ivory white. So the incorrect statement is Pseudomonas green color. This is the only correct statement. Rest all are wrong. This is the only correct statement. Rest all are wrong. Clear everyone? Great. Moving to the next question. A patient of leprosy presented with painful lesions on the arm as shown. He is also febrile. He is given a drug which increases the numbness of the hand and foot. What is the likely diagnosis? You can see that on the arm there are some swellings or some nodules. So can you tell me in which type of leprosy you see these nodular lesions? Anyone? Where do you see the nodular lesions? In which form of leprosy? In which form of leprosy you see these nodular lesions? please remember this is a patient with very classical type 2 lepra reaction. Which is known as erythema nodosum leprosum. The most effective drug which you use for these individuals is thalidomide, and please remember one of the very frequent side effects of thalidomide is it causes the peripheral numbness. Can you tell me what are the other side effects? What are the other side effects of thalidomide therapy other than the peripheral numbness? Please remember, other than this, we have a lot of other side effects, and the side effects of thalidomide: peripheral neuropathy, then you have edema of the periphery, increase somnolence, patient will feel very sleepy. These individuals can also develop constipation, and it's a highly teratogenic drug. These are some of the side effects of thalidomide therapy. So please remember, this is a patient with a very classical erythema nodosum leprosum like reactions. Next question. A 28-year-old boy, I'm very sorry for this, the questions are actually not fitting up into the box, I don't know why. A 28-year-old boy has asymptomatic dome-shaped small lesions on the forehead for last 2 months. He has a 2-year-old daughter with similar lesions. What can be the causative agent? So first of all, I want all of you to please look at this image. Can you tell me the diagnosis here? What is the diagnosis? Looking at the lesion, very classical, discrete, you see, very classical, discrete pearly papules with central umbilication. Discrete pearly papule with central umbilication. Discrete pearly papule with central umbilication. This is a very classical diagnosis of molluscum contagiosum. And please remember, molluscum contagiosum, it is a pox virus. So a 28-year-old boy has asymptomatic dome-shaped small lesions on the forehead. He has a 2-year-old daughter with a similar lesion. Please remember, it's a highly contagious condition. It's spread from one person to another. The causative agent for this condition is pox. Option number 1 is the correct answer. Great. Moving to the next question. What is the correct answer? A patient of lepromatous leprosy started on treatment. He develops erythema nodosum leprosum with fever. He reports a change in the skin color. The therapy as shown in the image. What is the likely diagnosis? What is the likely diagnosis in this patient? Great, very nice. Please remember, you give a drug which is known as clofazimine in treatment of leprosy, and one of the very common side effects of clofazimine therapy is pigmentation. Can anybody tell me what are the other side effects which you can see in the patients who are treated with clofazimine? Pigmentation of the skin is the first and the most common. You can even see discoloration of the skin, that is pigmentation, dryness of the skin, and you can also see presence of intestinal obstruction. You can also see intestinal obstruction. So these are the side effects secondary to clofazimine therapy. These are the side effects secondary to clofazimine therapy. Next question. What is the diagnosis? A parous woman with non-tender indurated ulcers on the genitals with no inguinal lymph node. What is the diagnosis? What is the characteristic diagnosis here? Very nice. The question mentions that the patient presents with non-tender indurated ulcers. I don't know why everybody is marking LGV. In LGV there is no ulcer. In LGV there is no ulcer. The presence of painless hard ulcer it's a very classical feature of syphilis. So the correct answer of this question is option number 1. It is not LGV. A parous woman with non-tender indurated ulcers with no inguinal lymphadenopathy. Please remember, in the patients of LGV, inguinal lymphadenopathy is almost always increased, or it is almost always present. So you cannot mark this question as a question of LGV because the lymph nodes are not enlarged. The correct answer of this question is option number 1, syphilis. The correct answer of the question is option number 1, syphilis. Next. All of the following infections present with maculopapular rash except. What is the correct answer? Anybody can tell me here? Very nice. Please remember, in all of them, they have presence of maculopapular rash, but shingles, which is the another name for herpes zoster. Herpes zoster classically present with grouped vesicle over the dermatome. Grouped vesicle over the dermatomal distribution. Grouped vesicles over the dermatomal distribution. That is a very classical presentation of the patients with shingles. It will never present with vesiculobullous lesions. Next question. Patient comes with itching in the groin since 2 weeks. All of the following can cause it except. The patient comes with itching in the groin since 2 months. All can cause this except. What is the correct answer here? Very nice. Please remember, aspergillus. This is a very classical example of Tinea cruris. It's a very classical example of Tinea cruris, and please remember, the Tinea cruris is a dermatophytic infection. And we have only 3 species of dermatophyte: trichophyton, epidermophyton, and microsporum. Aspergillus is not an example. Aspergillus is not an example. Clear, all of you? Aspergillus is not an example. Next. A patient with following lesions. Investigation shows coca in long chain. Can you tell me, if they have given only this thing, what can be the organism? Can you tell me in which organism you see coca is in the long chain? Very nice. It is the streptococcus infection. Very nice. So patient presenting with following lesion, you can see that there is honey colored or yellow colored crust which is present. There is honey colored or yellow colored crust which is present. The correct answer of this question is impetigo contagiosa, which is nothing but another name for non-bullous impetigo. It is nothing but another name for non-bullous impetigo. Nothing but another example of non-bullous impetigo. Clear, everyone? An 8-month-old child with itchy exudative lesions on the face, palm, soles, sibling also have the similar complaint. The treatment of choice for such patient is. Can you tell me the diagnosis? Very nice, Ashwarya. This is a very classical description of scabies, which is a parasitic infection. And for treating scabies, you give topical permethrin. You give topical permethrin. Can anybody tell me what is the mechanism of action of topical permethrin? The correct answer is this. But what is the mechanism of action? It works by blocking the sodium channel. It causes efflux of sodium. It opens the sodium channel, not block. It opens the sodium channel, causing the efflux of sodium, and that is how it causes paralysis in the mite, causing its death. So please remember, it works on the sodium channel, unlike ivermectin, which works on GABA-gated chloride channels. GABA-gated chloride channels. Next, there is no fever. A patient of leprosy presented with lesions as shown since 7 days. The lesions are painful. There is no fever. What is the drug of choice? What is the drug of choice? First of all, tell me what is happening in this patient. Anybody? What is happening here in this patient? What is happening in this particular patient? Please remember, this is a patient with type 1 lepra reaction, where there is inflammation, erythema, pain on the existing lesions. And whether it is type 1 or type 2, the treatment of choice, always remember corticosteroids. In lepra reaction, please remember, whether it is type 1 or type 2, the drug of choice is always corticosteroids. So here this is actually a case of type 1 lepra reaction, and that is why the corticosteroid becomes the treatment of choice. Next question. Which of the following causes bacterial vaginosis? Gardnerella, Mycoplasma, Ureaplasma? What is the correct answer? Which of the following causes bacterial vaginosis? Very nice, great. The correct answer of this question is all of the above. Please remember, bacterial vaginosis is a condition which occurs because of decrease in the pH of the vagina. The pH of the vagina becomes more alkaline because the normal lactobacillus count goes down. When the normal lactobacillus count goes down, the pH increases, and that pH becomes very suitable for the growth of other organisms. So what happened in these individuals? They have a mixed sort of infection with all type of organisms, whether it is Gardnerella, whether it is Mycoplasma or Ureaplasma, Urea lyticum. So the correct answer of this question is option number 3, not only option number 1. Clear, everyone? Next. Which is the single best drug for treating the combined gonococcal and non-gonococcal infections of the cervix? The best single drug for combined gonococcal and non-gonococcal infection. Please remember, if you have to choose one drug, it is azithromycin, because ceftriaxone will work on gonococcal, but it will not work on non-gonococcal infections. So the correct answer of this question becomes option number 1, azithromycin. Azithromycin. A A child presented with the lesion as shown in the image, what will be the diagnosis? A child with the image shown, what will be the diagnosis? Bullous impetigo, staphylococcal scarlet skin syndrome, candidal intertrigo, or scrofuloderma. Anyone? Great. Please remember, this is a very classical image showing the candidal intertrigo of the neck. And if you notice here, these are some of the satellite lesion, which is a very characteristic feature of intertrigo. And it occurs usually in children because of moisture, which is one of the very important precipitating feature for development of intertrigo. Next question. A newborn child with solitary white, well-defined patches on his left thigh. Newborn is a very important clue here. They say that it's a newborn infant. A very important clue. A newborn child presents with solitary well-defined patches on his left thigh. What is the diagnosis? Very nice. It's a very classical example of nevus acromicus, which is also known as nevus depigmentosus. Nevus acromicus, also known as nevus depigmentosus. Nevus acromicus, also known as nevus depigmentosus. This is a congenital condition where the melanocyte migration is defective, giving rise to a hypopigmented lesion with a very classical serrated margin present since birth. Next question. A 15 centimeter hyperpigmented macule on an adolescent male undergoes changes such as coarse growth of hair, acne. What is the diagnosis? What is the diagnosis? Very nice, Aditi, Prakash, Rahul, Neeraj, Karthik. Please remember everyone, the correct answer of this question is option number 2. It is a very classical example of Baker's nevus. I want everyone to please look at this image. Baker's nevus is an epidermal nevus which has androgen receptors on them. So what happens at the time of adolescence? The circulating androgen increases, and that is why the nevus cells will also proliferate, giving rise to the brownish pigmentation of mainly over the trunk with associated hairs, or even in few cases you can see little bit of acneiform eruptions. Very classical image of Baker's nevus. Very classical image of Baker's nevus. Which of the following does not cause urethritis in a male patient? Which of the following does not cause urethritis in a male patient? Which of the following does not cause urethritis in a male patient? Anyone? Now please remember the correct answer of this particular question is option number 1. Why it is option number 1? Because urethritis can be because of two causes, non-gonococcal and gonococcal causes. The gonococcal causes of urethritis is Neisseria gonorrhea, while non-gonococcal causes are chlamydia, mycoplasma, ureaplasma, and even in Trichomonas vaginalis. Trichomonas vaginalis can cause urethritis in male. We are not talking about vaginal infection. It cannot cause vaginal infection in the male, but it can cause urethritis. So please remember the correct answer of this question is option number 1, which is responsible for formation of genital ulcers, not urethritis. It forms a very classical, painful, multiple ulcers with undermined edges. So please remember there is a difference between both of them. Next question. What is the correct answer? What is the correct answer? Anyone? Great. Please remember onychomycosis. What is onychomycosis? Am I audible and visible to all of you? Great. Onychomycosis means the fungal infection of the nail. We have special formulations which is known as nail lacquer formulations. Which is a sticky sort of formulation, very very effective for the nail plate infections. And onychomycosis is one of the very frequently seen infections where you use nail lacquer formulations like amrolfin or cyclopyrox. Amrolfin or cyclopyrox. Next question. Identify this test. Prick test, contact dermatitis. Patch test, contact dermatitis. Pathology test, Behçet's disease. Pathology test, pyoderma gangrenosum. What is this test which is seen? Very nice. Lakshmi, Prince, John, Sid, Prakash, Aishwarya. Very nice. The correct answer of this question is it is a very classical image of a patch test. You can see it here. The panel which we have, it includes 20 allergen and we get them as a pre-filled syringes in the market. Now you apply each antigen in the aluminium chamber which is available, which is known as fin chamber, and with the help of the micropore you stick it on the upper back of the patient. Why do you choose the upper back of the patient? Because it is a very least mobile area. You ask the patient to come back after 2 days, that is on 48 hours you will remove the patch, and again after 2 days, that is on 96 hours, you will read the patch. So 48 and 96 is the correct answer. 48 and 96 would be the correct answer. Clear everyone? Any confusion? Anyone has any confusion? Okay. Which of the following is true association? I think we have done this question recently. I want everyone to remember this. We have done this question recently. The true association amongst the option provided is, yes, you're right, psoriasis and metabolic syndrome. There's an increased risk of development of obesity, hyperlipidemia, diabetes mellitus, and ultimately the heart issues in the patients of psoriasis. Next question. Treatment of multivasillary leprosy is. What is the treatment of multivasillary leprosy? 2 drugs in 12 months, 2 drugs in 6 months, 3 drugs in 12 months, or 3 drugs in 6 months. What is the correct answer? Treatment of multivasillary type of leprosy. Great. The answer to this question is, for multibacillary, WHO have created a paucibacillary group and a multibacillary group. Paucibacillary means when you have skin lesions 1 to 5. If the nerve is involved, it is plus minus 1, and the slit skin smear is negative. While multibacillary means skin lesions more than 5, nerve involved is more than or equals to 2, and slit skin smear positive. The difference in two is you give 3 drugs for 12 months in multibacillary, and in paucibacillary you give 3 drugs for 6 months. Because the question is asking multibacillary, the answer becomes 3 drugs in 12 months. Okay, so please remember, this is a very important point. Let's move to the next question. Should we go to the next question? Yes. Which mineral deficiency can lead to following condition? Aditi, it would be best if you answer 3 drugs for 6 months, which is set by WHO, because that is the recent guidelines which says a uniform MDT where you give 3 drugs for 6 months in both the cases. So 3 drugs protocol is used. You can see that there is periorifacial dermatitis. So what is the diagnosis? Which mineral deficiency can lead to the following condition? The correct answer is option number 1, and you all are right that this is an image which shows a condition which is known as acrodermatitis enteropathica. It's a condition with acrodermatitis enteropathica. Acrodermatitis enteropathica. Clear? Next question. Identify the condition shown in the image. You can see some pedunculated lesions around the perianal skin. Some pedunculated structures are seen. What is the diagnosis? Very nice. The correct answer of this question is option number 1, that is condyloma acuminata. This is a very classical image of genital HPV infections, and I think this we have discussed so many times, that HPV 6 and 11, which is a low risk HPV, causes this disease. A low risk HPV which causes this disease. Clear all of you? Next question. Condyloma lata is a feature of secondary syphilis. You have flat moist lesion in condyloma lata. So please remember, Rahul, that it cannot be condyloma lata. There are flat lesions. But if you look at that image, it has pedunculated lesions. Which of the following will show canker redux? Early relapsing syphilis, chancroid, late syphilis, or herpes? Very nice. The correct answer of this question is in early relapsing syphilis, there is reappearance of the primary canker. There is reappearance of the primary canker, and this reappearance of the primary canker over the site of previously healed ulcer is known as canker redux. It's a very classical feature of early relapsing syphilis. Early relapsing type of syphilis. Very classical feature of early relapsing type of syphilis, which is not seen in the patients of Behçet's disease. Which is not seen in the patients of Behçet's disease. What is the correct answer? Which is not seen in Behçet's disease. Which is not seen in Behçet's disease. Anyone can tell me the answer here? Very nice. Please remember, in Behçet's disease, the lesion which is present in the skin is erythema nodosum, not erythema induratum. Erythema induratum is one of the uh, hypersensitivity reaction which occurs secondary to tuberculous infection. So erythema induratum is actually a tuberculate. In Behçet's disease, the cutaneous lesion which you see is erythema nodosum. So this becomes the wrong statement. This becomes the wrong statement. In which condition you see the Max Joseph space? In which condition you see the Max Joseph space? Psoriasis vulgaris, pityriasis rosea, lichen planus, parapsoriasis. Max Joseph space is a histopathological feature of. Max Joseph space is a histopathological feature of. Very nice. The answer is lichen planus. When the degenerated stratum basale is gone, the empty spaces are left behind, and through those empty spaces, the pigment falls down. That is known as Max Joseph spaces. It's a feature of lichen planus. Next question is on your computer screen. Pseudo-isomorphic phenomena is seen in. Pseudo-isomorphic phenomena is seen in psoriasis, vitiligo, wart or DLE. Pseudo-isomorphic phenomena is seen in psoriasis, vitiligo, wart or DLE. Please remember, the correct answer of this question is option number. Pseudo-isomorphic phenomena or pseudocobnus. Pseudo-isomorphic or pseudocobnus phenomena, it occurs because of auto-inoculation. And auto-inoculation is only possible in the infectious condition. So viral wart, molluscum contagiosum, all of them have pseudo-isomorphic phenomena present in them. Clear? Not a feature of scabies. Prince, in vitiligo you see true cobnus, not pseudo. So vitiligo, lichen planus and psoriasis you see true cobnus. Pseudocobnus is seen in infectious conditions. Very nice. Sid, Prakash, Adil, Lakshmi, Arita, Rameshwar, Aishwarya, Rahul, Adil. The correct answer, not a feature of scabies. The correct answer is, you will never get fever as the common finding. No, this is not correct. Fever as the common finding is not a correct statement. Clear? Fever only occurs when the lesions get secondary infected. Pustules are formed. Otherwise, in scabies, fever is not a presenting complaint. Otherwise, in scabies, fever is not a presenting complaint. Next, we recently got a question from the same topic. 2022, we got a question from the same topic. A 40-year-old man with diabetes has the following lesions in the axilla and the neck. What is the diagnosis? Very similar lesion we got recently. So please remember, the correct answer of this question is you have a hyperpigmented velvety plaque on the flexures in a patient with metabolic syndrome like diabetes, hyperlipidemia, very classical of acanthosis nigricans. Now can you tell me, if you see the same lesion in an elderly, what does it signifies? If you see the same lesion in an elderly patient, what does it signifies? Anyone? Same lesion in an elderly patient, what does it signifies? It gives you an idea of underlying associated gastric adenocarcinoma, because acanthosis nigricans is also a paraneoplastic condition. It's also a paraneoplastic condition. Acanthosis nigricans is also a paraneoplastic condition. Very nice, great. Next, patient with a rash of more than 30% on the skin with hemorrhagic crusting on the lips. What is the cause, or what is the answer? Hemorrhagic crusting with peeling of the skin on more than 30% of the area. Anyone? Sana, Lakshmi, Rameshwar, Yogesh, Neeraj, Aditi, Ankur. What is the correct answer? Very nice. This is a very classical example of toxic epidermal necrolysis. A very classical example of toxic epidermal necrolysis, and please remember, drugs are the most common cause. The answer of this question becomes option number 1. Prince, why this is not 10? Because in SJS, the body surface area is less than 10%, and in 10 it is more than 30%. So the question clearly mentioned that it is 10% and beyond, so it should be toxic epidermal necrolysis. Mucosal involvement is seen in both. In SJS also the mucosa is involved. In 10 also the mucosa is involved. So it is not the mucosa which decide whether it is 10 or SJS. It is the body surface area involved which decide whether it is SJS or 10. Clear, everyone? Which of the following is not a feature of mycosis fungoides? Not a feature of mycosis fungoides. Tell me what is the answer of this question. Very nice, very nice. So which of the following statement about mycosis fungoides is not true? Please remember, the correct answer of this question is it has an indolent course or a good prognosis. No, that is not true. Prognosis of mycosis fungoides depends upon the stage, whether it is a plaque stage, a papule stage, or a pustular stage. It doesn't depend upon the, or you cannot comment or give a generalized prognosis, because the disease depends, the prognosis depends upon the stage. It is the most common cutaneous lesion, that is true. The most common lymphoma, of the skin. Porphyrias microabscess is the collection of T lymphocyte. Again, it is true. And you can even develop a later stage erythroderma, which is a grade 4 CTCL. But that statement which says that the prognosis is good is not correct. Clear? Anagen phase of the hair indicate what? The anagen phase of the hair indicate what? The phase of activity, growth, the phase of transition, the phase of resting, or the phase of degeneration. So anagen phase of the hair indicate what? Very nice. Rupa, Rameshwar, Sana, Rahul. The anagen phase, we have three phases. We have anagen, which is the growth phase. We have catagen, which is the phase of degeneration or catabolism. We have telogen, which is the phase of resting. So that is the hair cycle. The correct answer of the question is it is a phase of activity and growth. The duration of anagen phase decides the length of your hair. It is the duration of the anagen phase which decides the length of your hair. Alopecia areata is not associated with which of the following condition? Alopecia areata is not associated with which of the following condition? Exclamation sign, atopy, pitting, or geographic tongue. Alopecia areata is not associated with which of the following condition? Exclamation sign, atopy, pitting of the nail, or geographic tongue. Very nice. The correct answer of this question is it is associated with exclamation sign. This is true. It is associated with pitting of nail, and you can also see few sort of lesions where there is association with atopy, but geographic tongue, which is not that frequently associated with alopecia areata compared to that of psoriasis. So the correct answer of this question becomes option number 4. Clear? Moving to the next question. What is the correct answer here? A child with erythematous non-blanching bosselated lesions on the right side of the face, what is the treatment? And Apurva, may I ask that why are you asking that question? Tell me what is the answer. The child with erythematous non-blanching bosselated lesions on the right side of the face, what is the answer? The erythematous non-blanching bosselated lesions on the face. Can you tell me what can be the diagnosis? Can anybody tell me what is the diagnosis? This could be a patient with infantile hemangioma, or to be more specific, it could be a vascular lesion. And please remember, for a vascular lesion, you use a laser which is known as flash lamp pulse dye laser. Flash lamp pulse dye laser. Clear, all of you? Now, moving to the next part. Bleeding spots seen on removal of scales in psoriasis is called as. The bleeding spots seen on removal of scales in psoriasis is known as. What is the correct answer? Bleeding spots seen on removal of scales in psoriasis is called as Auspit sign, punctate hemorrhages, Nikolsky sign, or Darius sign. You all are right that the correct answer of this question is Auspit sign. Can you tell me where do you see let's start with all the options. Where do you see Darius sign first? The answer to this question is option number 1, but tell me in which disease you see Darius sign. Darius sign is a feature of Darius sign is a feature of urticaria pigmentosa. Darius sign is a feature of urticaria pigmentosa. What is Nikolsky sign? Nikolsky sign is a feature of intraepidermal vesiculobullous disorders. For example, pemphigus. While Auspitz sign is a feature of psoriasis. Auspitz sign is a feature of psoriasis. Auspitz sign is a feature of psoriasis. Clear? A 25-year-old female with nodular acne, hair loss on the scalp with increase of the central parting, what is the drug of choice? Anyone? Punctate hemorrhages, see, punctate hemorrhages is nothing, it's just it's not a sign. In fact, Auspitz sign, one of the step is the punctate hemorrhages. So, Auspitz sign is a 3-step procedure. The last step is the punctate hemorrhage. So, the best answer of that bleeding point, the answer should be Auspitz sign, not the punctate hemorrhage. Clear? The correct answer of this question is cyproterone acetate. Now, why this is the correct answer? The question clearly mentions that a female with nodular acne and loss of hair with increase in the central part. This is a very classical feature. Arita, you are absolutely right that punctate hemorrhages can also be the answer. But you have to pick one best possible answer, and Auspitz sign is the best possible answer for that particular question. Clear? The answer to this question is cyproterone acetate. The reason is the increase in the hair loss with widening of the central part. It is a very classical feature of female pattern hair loss, which is nothing but androgenic alopecia. So in a young patient with androgenic alopecia and nodular acne, it means that circulating levels of androgens are increasing. And whenever you have increase in the circulating levels of androgen, you have to give anti-androgen drug. So the only anti-androgen drug which is available is cyproterone acetate. Clear? If you give anti-androgen, it will cause improvement in both hair loss also as well as in the nodular lesions as well. Hair loss as well as nodular lesion also. Please tell me the correct answer here. What is the correct answer? Please tell me the answer here. What is the correct answer here? Anyone can tell me the correct answer here. Very nice, all of you. We have a 9-year-old patient with multiple itchy wheals all over the body for 2 days, no respiratory difficulty. What is the best treatment available? Now, please remember, all my students, that this is a very classical example of urticaria. How to treat urticaria? Whether you have a mild or a severe variety of urticaria, you always treat urticaria with antihistaminics. Why we are not giving corticosteroids in a severe form of urticaria? Please remember, the corticosteroids are only indicated whenever you have respiratory difficulty. For example, in angioedema, swelling of tongue, swelling of larynx, which is creating difficulty for the patient to breathe. Otherwise, even if you have severe form of urticaria without any respiratory difficulty, you will never treat the patient with corticosteroids. So the correct answer here would be antihistaminics. The correct answer here would be antihistaminic. Okay? Clear, all of you? Great. Now moving to the next question. What is the correct answer here? For treating tinea cruris, for which drug there is a widespread resistance developing in the last 2 years? What is the correct answer? Itraconazole, griseofulvin, terbinafine or voriconazole? For treating tinea cruris, for which drug there is a widespread resistance developing in the last 2 years? The correct answer of this question is option number 2, that is griseofulvin. The correct answer is griseofulvin. Now, if I ask you the question in a reverse manner, can you tell me what is the or which is the drug of choice for treating tinea cruris? Can you tell me the answer of this question in the reverse manner? Very nice. The correct answer is, if you are treating a patient of dermatophytic infection other than tinea capitis, the correct answer is terbinafine, which is the drug of choice. But for tinea capitis, still griseofulvin considered to be a good drug because the most common species of dermatophyte causing fungal infection of the scalp is Microsporum, and griseofulvin is a very effective drug against the Microsporum infection. Okay, ji. Now I think this would be the last question, the last question of the today's session. Can you tell me the answer here? This phase of the hair cycle determines the length to which the hair in the different body part grows. Now actually there was a question which was asked in the AIMS exam. The question was, why the length of the eyebrows never exceed beyond a certain length? For example, they are always short. Nobody goes and cut their eyebrows, but you always have to go to cut your scalp hairs. The reason is because the duration of the anagen phase is very small. The duration of the anagen phase is very small. The duration of the anagen phase is very small in the eyebrows, and we have already discussed that the length of the anagen decides the length of the hair. So because the length of anagen is very short in the eyebrow hairs, and that is why you could not, or they could not grow to that particular length. So with this, we are done with today's session. Thank you all of you. For any queries, you know where to find me. So requesting all of you to kindly join. My name is Dr. Chesta Aggarwal. For dermatology classes, you can find me anywhere. Thank you all of you. Good night. Take care.